Stop and raise your right hand. Do you swear or affirm that any testimony you give in this trial will be the truth, the whole truth, and nothing but the truth, so help you?
Yes.
Please be seated then. Now that you're seated, please state your name in full and spell your last name for the court's record.
Benjamin Silva, Benjamin Silva.
Go ahead, counsel.
Mr. Silva, is that right if I call you Ben for the purposes of today?
Yes.
What is your current position with the Camas-Washougal Fire Department?
I'm a shift battalion chief.
And what training and experience do you have to prepare for that role?
I went through a fire academy, became a firefighter. I also went through paramedic education, certification as a paramedic for many years. After about 14 years as a firefighter, I got promoted to a captain position, overseeing my station crew, and then promoted to battalion chief about 6 years ago.
And what does the Fire Academy involve?
That's a 3-month intensive training academy to teach us all about firefighting operations.
And what do those firefighting operations include?
So the firefighting operations include both fire and emergency medical services. So how to fight a fire, how to rescue people from car accidents, how to treat patients that might be having medical emergencies.
Could you ask the witness to speak up just a tiny bit? Get your voice up, the matter is being recorded.
And were you always with the Camas-Washougal Fire Department?
That is where I've served the entirety of my fire service career.
Can you explain what your roles and responsibilities are as a battalion chief?
The battalion chief is the shift supervisor. We have 3 fire stations that we oversee in Camas and Washougal. The battalion chief does a lot of the administrative work day to day, and I work a 24-hour shift, the same as the rest of the firefighters that work under me. And then I respond on calls that are of high importance or have multiple resources like structure fires, major car accidents, and cardiac arrest calls.
And you said calls of high importance. Is there like something that you call those types of calls?
High acuity or high priority calls.
And I'll get back to high acuity calls in a second, but I want to go over a little bit more of the structure of the Camas-Washougal Fire Department with you, if that's okay. You indicated that there are three fire stations. What are those 3 fire stations?
Fire Station 41 is a central station in downtown Camas. That's where my office and dorm is located, and has myself, a fire engine, and an ambulance. Station 42 is on the west side, bordering Vancouver, has a fire engine and ambulance there, and then Station 43, which is in Washougal, just off of SR 14 and Washougal River Road, and that has a fire engine and ambulance crew there as well.
So as far as the Camas-Washougal Fire Department as an organization, who's kind of the head honcho?
So the chief of the department would be the top of the department, and then there's an EMS division chief and a fire prevention division chief that oversees fire marshal duties. And then below that is going to be the battalion chiefs who oversee the day-to-day operations of the crews.
And now in 2023, going into 2021, who are the 3 fire battalion chiefs?
Myself, Kevin West, and Kevin Valines.
And which crew were each of you assigned to? I'll break that up. You were assigned to 41, is that correct?
Yes, all the battalion chiefs worked out of Station 41. We rotated through that position in 24-hour rotations.
And then so it's not that they're assigned to different, like one would be 42, one would be 43, one would be 41?
No, each battalion chief for that 24 hours oversees all of the 3 stations from that central Station 41.
And then so as battalion chief, I guess, who do you have under you?
The station captains are below the battalion chief, and so we usually interact with the station captain mostly, but then each station, the captain has 3 more firefighters that they oversee. So there's usually a total of 4 personnel at each station, one of them being a captain.
And so since Mr. West was one of the other battalion chiefs, did you know Mr. West?
Yes, I've known him since approximately 2000.
And when did you stop? How long? So you've known him since 2000. So how many years have you known him approximately?
Yeah, about 24, 25 years.
And so being on different shifts as the battalion chief, once you were both battalion chiefs, did you work together very much?
We no longer were able to be on a shift together because there's only one battalion chief per shift. So the way we would work together is essentially kind of at maybe staff meetings we'd interact, and then at shift change in the morning we would pass on information related to the department, sometimes any personal stuff as well.
So what happens at a shift change?
It's just a time where the offgoing shift passes on all the pertinent information on equipment, personnel that is going to be pertinent to keep operations continuing on for the next 24 hours. So it's kind of like a reporting maybe important things that have happened during their shift so that you're ready to address any of those issues that might remain.
Now, earlier you mentioned high acuity calls. What is, in Camas Washougal Fire Department, what is considered a high acuity call?
Usually, the way dispatch categorizes calls, there are different priorities, as low as priority 6 and up to priority 1. So, usually a high acuity call would be a priority 1 call, something like a cardiac arrest.
What are other examples of high acuity calls in addition to cardiac arrest?
If we're talking about medical calls, things like a active chest pain, active seizure, respiratory arrest, maybe a drug overdose, things like that. Other high acuity calls would be more fire or rescue related, like structure fires and major car accidents.
So at a high acuity call, like a cardiac arrest, what does the response look like from Camas Washougal Fire Department?
Usually, if it's dispatched as a cardiac arrest, we'll get a battalion chief, 2 fire engines, and a medic unit or ambulance.
So you said battalion chief, 2 fire engines, and what was the last one?
A medic unit, also ambulance is the lay term, I guess.
And now why would a fire engine need to go to a cardiac call?
It requires a lot of manpower to deal with a call like that. We have EMTs and paramedics on our fire engines as well, so we're dealing with maybe helping someone breathing for them, getting IV access, doing chest compressions, trying to find a path out of the home if we're going to be transporting and we're on a second floor or basement. We're going to need equipment to help get the patient out, and we're going to need manpower. Also, we've got to talk to family, see if we can find out what their medical history is, anything that might give us clues as to how we could assist the patient.
And what is the role of a battalion chief at a cardiac or high acuity call?
Usually I'm the battalion chief it's kind of hands off of the patient most of the time. Usually the fire engine crews and ambulance crews are hands on with the patient or doing active patient care. The battalion chief usually fills a role of liaison with family, trying to find out medical history, medications, and reporting back to the family member of progress, if there's progress or not progress with the patient, and then just making sure the scene is overall safe.
What medical certifications have you held during your career as a firefighter paramedic?
I've been an EMT basic, an EMT IV technician, and then an EMT paramedic.
And what's the difference between an EMT basic and an EMT tech?
EMT basic is kind of one of the sort of entry levels into EMS, able to do things like CPR, help splint bones, things that aren't going to be not administering medications or that sort of thing. We're starting IVs, we're doing advanced airway. An IV tech has the ability to start IVs and give fluids, so that it adds a little bit of a capability that EMT basic does not have. And then EMT paramedic would be able to give medications, defibrillate a patient, that sort of thing.
Now, did you, prior to, I want to talk before we get to January 2025, did you know Marcy West or Marcy personally?
Yes, as in the fire department, we, especially when I started, the department was smaller. We knew a lot of the family members of our coworkers, so I've known Marcy through that, and over the years I'd seen her a few times at things like a dance practice or something that my daughter had at the same time that her daughter would be there. So I've known her. I've had conversations with her.
Would you say it was a close relationship?
I would say acquaintance.
I want to talk about the dispatch and response on January 2025. Sorry, 2024. Dispatch and response on January 8, 2024. Turning to January 2024, can you describe what your duty status was when the initial call came in?
I was on duty as the shift battalion chief. It was the middle of the night, so I was in my dorm. Yeah.
And so when a call comes in from, say, is it Cressa that you all work with?
Yes.
So once a call is made to Cressa, how is the fire department alerted?
So Cressa.
Hang on just a second. Juror number 2, you're all right?
Yeah, I'm all right.
All right. I can't afford to lose a juror every couple hours. Need a drink of water or something. Let's go.
Use it too.
Go ahead, Councilman.
Sorry. So working with Cressa, when someone makes a 911 call, what does that look like as far as that information being transmitted to Camas-Washougal?
So Cressa is the dispatch agency. They determine what the call reason is, and they prioritize it, and they have automatic sort of protocols that they go through to send the unit that's best set to respond to it. So in this case, they, I believe it was dispatched as a seizure initially, and they dispatched a fire engine and ambulance from the Washougal Station 43 to respond.
So with the initial part of the call being a seizure, was that something that the battalion chief, you as the battalion chief, were going to respond to?
No, I do not respond to those. I do get the pages on my phone that give me the call type, and so I'll usually look at the call type and make sure it's not something that I should respond to. In this case, I didn't initially respond.
Was the call elevated at any point?
At some point during the response, I don't know if it was dispatch or the responding engine or medic unit, but it got upgraded to a cardiac arrest, CPR in progress, and at that point I began to respond as the shift battalion chief, and I believe a second engine was dispatched as well.
And so, since you're responding afterwards, did you arrive on scene after resuscitation efforts had already begun?
Yes.
And what were your initial observations?
I arrived to the house, just went in the front door, went upstairs. The crews were treating Marcy and doing resuscitation efforts. Washougal Police was there, and I believe the East County Fire Engine crew was there as well.
At what point during either getting there or otherwise did you realize that the call involved the West residents?
While I was responding, I kind of realized in my mind, exactly where kind of the block that this call was on, and I recognized that as where Kevin and Marcy lived. And at that point, I double checked on my screen, flipped to a different tab where I could see the caller name, and I believe it said Kevin West. At that point, obviously, I knew it was Kevin and Marcy's house. So I was probably over halfway there by the time it actually kind of I realized who it was.
And you mentioned a screen that you were checking. What are you talking about?
We have a laptop computer mounted in our pickup, which is what I respond in as a battalion chief, and it has a link to Cressa with their dispatch information that they enter, and so we can see things like the address, the caller, that sort of thing.
And so is the purpose of that so you all know what you're looking at, like what you're going to be going into?
Yeah, it gives us just gives us more information for when we're responding. Sometimes we'll use the phone number or the name to call that person that not in a situation like this, but maybe a fire alarm or something. If that information is helpful.
When you arrived on scene, what was your role in the response, aside from just the title of battalion chief?
It's kind of like I said before, looking at the overall scene, making sure things are, we have the right resources, make sure if we need any more personnel, we get them called. But in this case, I went in the room where Marcy was being treated in the bedroom, and I went over, and Kevin was kneeling on the floor near her, and I just put my hand on him and tried to offer some comfort while I was watching the crew, making sure that everybody was, able to do what they needed to do.
And now, as the battalion chief, when you're arriving on scene, are you involved directly with the patient care itself?
Not usually.
And why is
Usually we have enough personnel for what I consider the hands-on care of the patient, and my EMS role is not what it used to be. It's just expected that we're more in a supervisory role for the overall scene.
So then on January 8th, 2024, were you involved directly in the patient care of Marcy West?
No.
After you arrived in the room upstairs, what did you do next?
As I said, I went over to Kevin. I tried to comfort him, kind of looking around and seeing that the crew was doing their patient treatment as they normally would. After a while, and seeing that there was not a positive response to our efforts, I got up and left the room for a few minutes to try and alert our chief and my supervisors.
You said that you were noticing that there wasn't a positive response to the efforts. What do you mean by that?
I don't recall that there was a change in the cardiac rhythm. I don't recall anybody calling out that there was a change or improvement in the cardiac rhythm in the information that we have from the monitor.
And based on your training and experience, how did that inform your next decision to call?
It seemed like it was going to be a poor outcome for her, and that we likely were not going to be successful in resuscitation.
Can you explain why he was allowed? Is it normal for loved ones to remain by the patient?
Not usually, because we normally we have to be taking care of the patient airway and helping them breathe, and so a lot of times we'll ask the loved ones to step away while we do those things. Kevin was in a position where he wasn't in the way, and we knew he understood the efforts we were doing, so we didn't have him move at that point.
Aside from allowing him to remain nearby, did you observe anything about the scene that differed from standard procedure?
I did not notice anything different or out of the ordinary.
No further questions, John.
Cross-examination.
Thank you, Honor. Good morning, Mr. Silva.
Good morning.
This way I can hear you just a little better. I'm sitting a little ways back, and I think my hearing's not what it used to be. Now, you're in Station 41, which is around downtown Camas, just across from the Safeway, right?
Correct.
And then there's the 43, which is the Washougal one.
Yes.
Over the freeway and where River Road comes in there.
Yes.
And then 42 would be over kind of by off of Parker.
Yes.
And so 41's kind of centrally located, right?
Yes.
So you can go both directions.
Yes.
Now, you were talking about the process of the call. When somebody calls 911, the dispatcher is trained to ask certain questions to know who to dispatch, correct?
Correct.
And automatically this is coming out in real time to the stations, and you're getting this information as it happens, right?
Correct.
And so how do you get notice that a call is in progress and that your help might be needed?
We have a app on our phone that will send us an alert once dispatch has received a call that they've determined is a fire or EMS call. And once, so we kind of have a pre-alert on that usually, and then they determine exactly what the call is, and they dispatch it using tones over the radio that set off a system in our stations that turns on the lights and turns on speakers so that we know that there's a call, and it announces what the call is and where it's at.
So this is while you're sometimes asleep, is that right?
Yes.
In this case, were you asleep?
Yes.
Okay. Kind of an unpleasant way to wake up?
Yeah, I'm used to it though. That's what we do.
I'm sure. Okay, so the alarm goes off, you get dressed real quick, get your stuff together and get out the door if you're required, correct?
Correct.
Now, when this call is made, does the caller say, listen, I need an ambulance, I need a paramedic, I need something? Do they have to say what they need?
Not to my understanding. Usually they say what their problem is, and then dispatch kind of determines the need.
But now, as a paramedic, you're still paramedic, or you're EMT now?
I am an EMT now.
Okay, you were a paramedic and that lapsed, is that right?
Correct.
Okay, all right. And so, but now in your position, having been there a long time, you know that this is automatic, the dispatcher is contacting the right people. They're not expecting the caller to make that call, right?
Correct.
And that's pretty basic knowledge for someone in your position.
Yes.
And you know that during this call, if you say there's a seizure, you know you're automatically going to get, did you say it was 2 engines and an ambulance?
1 fire engine and 1 ambulance.
Okay, so you're going to get probably 4 paramedics, or at least you're going to get probably 2 or 3 paramedics and a captain, right?
Yes.
In this case, it was 3 paramedics and I think Captain Castle, who's an EMT, right?
I believe so, yes.
Okay. And so, as a battalion chief with your experience, you know these people are going to show up.
Yes.
And they're going to be people from the closest station. You pretty much know who's going to come.
Yes.
Now, you said that you and Kevin have been both battalion chiefs. I'm sorry, when did you become battalion chief?
In late 2019.
Okay, and Kevin became one when, if you recall?
The year before, I believe.
Okay. So, starting about the time when you both became battalion chiefs, you didn't have as much time to spend together personally, is that right?
Correct.
Because you never worked the same shift anymore.
Correct.
Did you guys hang out personally?
No. Years ago, maybe a few times.
Right.
Decade.
But you weren't one of his hunting buddies or anything like that?
No.
Okay. But still good friends, respected peers, and so forth?
Yes.
Now, you say that you got to know Marcy a little bit, right?
Yes.
How many years did you, see her, like when your kids all had dance together? How long was it that you would see each other?
Like at a time, I guess, 20 minutes or something, sitting, waiting for our daughters to finish class. We might have some small talk.
I'm sorry, go ahead.
That's it.
Did you get to know her pretty well?
I felt like we were acquaintances. I, thought well of her.
Sure. And this was after how many years of seeing her at these events?
It's hard to say, a few years at least, but I've known her since Kevin got hired with the fire department, just through that connection.
Would she show up at some of the functions that you guys had?
I think so, especially when we were younger.
Okay, but as the years went on, not so much?
Correct. Not that I recall.
Now, this started out as a seizure call, you say, right?
That's what I recall, yes.
Normally, it's really common for seizures to be resolved before you get there, isn't it?
Yes.
So often you get there, report a seizure, you get there, the person's recovering, they might be in a daze or something like that.
Yes.
Or sometimes they might not be breathing, it might advance to a cardiac arrest.
Yes.
Now, Kevin, he was actually your FTO, wasn't he?
Yes.
Because that's field training officer?
Uh-huh.
So you got, is there S?
That is correct.
Okay, so he helped train you kind of for the position you're in?
He helped train me for my paramedic certification.
I see. Now, on January 8th, you were, I think, had you just started the new shift at that time?
Yeah, I believe we had just switched from a 3-shift system to a 4-shift system right around that time.
Okay, so like 4 24s?
It's more complicated than that, but it was 4 rotating shifts. Each shift was a 24-hour period.
And yours was from 7 a.m. till 7 a.m.
Correct.
So you were scheduled to get off that morning at 7 a.m.
Correct.
And in fact, the person scheduled to relieve you was Kevin, wasn't?
I believe so.
When you got to the house, you say you walked in the front door, right?
Yes.
Doors unlocked.
Yes.
And you say by that time you knew where you were going, right? You knew it was Kevin's place?
Yes.
Had you been there before?
I don't believe I'd been in the house, but I'd been maybe dropped something off or things like that. I just knew where his house was. I knew generally what it looked like from the outside.
And now when you got there were no police there yet?
I believe they were there.
Okay. So the advance team went first because they got the call, right?
Yes.
And actually, they were just coming back from another call at the time, isn't that right?
I'm not sure.
Seriously.
Yeah.
Okay. And as the battalion chief on scene, you're the supervisor, you're the top guy, right?
Yes.
Okay. But you're also kind of the gopher. You're an extra set of hands, aren't you?
Yes.
You sort of just do whatever everybody else can't do, just a lending hand.
Yes.
When you got there, you say that Kevin was kneeling beside Marcy's body, is that right?
Yes.
And but he wasn't trying to control anything, was he?
No.
He wasn't getting in the way.
No, I didn't. He wasn't in the way. I didn't hear him kind of giving any directions to anybody.
Did you hear him ask what the readings were on the monitor?
I don't recall.
Now, how was he behaving when you saw him?
He was emotional. Looked like he was crying, sad.
You ever seen him like that before?
I don't think so.
You say that when you got there, there was no cardiac rhythm, correct? If I'm saying that wrong, correct?
I don't believe so, but I was not in direct. I was not directing the medical care, so I can't say for sure.
You're familiar with the Lucas device, correct?
Yes.
And that's the mechanical CPR machine.
Yes.
You ever use that?
I've assisted with the use of it.
You're trained in using it.
Yes.
Now the way it works is that once you get it assembled, you get it on the person, you get everything hooked up, hit the go button, and it starts doing compressions.
Chest compressions. Yes.
And it's pretty effective, isn't it?
Yes.
And every 2 minutes a tone goes off, and you're supposed to stop it.
Correct.
And then at that time, you can look at the monitor and see what the readings are, right?
Correct.
Isn't it true that sometimes hearts can start and stop while you're rendering life-saving measures?
It's possible.
And so this runs for 2 minutes solid. You can't take readings because it's actually creating the readings, isn't it?
Correct. It obscures the rhythm while it's doing chest compressions.
And that, in fact, that's the whole purpose for the pause, is so that you can look at the readings.
Correct.
You've been on a lot of calls in your career, haven't you?
Yes.
You try really hard to save people, don't you?
Yes.
Can't save everybody, can you?
Correct.
And when you guys first get on the scene, by you guys, I mean paramedics, EMTs, all you guys, this is literally the definition of an emergency, isn't it?
Correct.
You're going fast and doing things as well and as quickly as you can.
Yes.
And you need room to work around something, don't you?
Yes.
So if there's something kind of in the way, the first people in are going to get that thing out of the way.
Yes, and in a cardiac arrest, we need room to do compressions, start IVs, and take care of the airway. So we'll either move the person to a clear area or move things around the person to give them a clear area.
So you got the guy doing the heart monitor who's kind of working toward the feet.
Usually, yes.
Okay, then the guy doing compressions or working the Lucas device is kind of in the middle.
Yes.
And you got someone at the airway at the top.
Yes.
And they're usually above the person's head.
Yes.
Now, before you get before you get the eye gel in place, you know what the eye gel is.
Yes.
What is the eye gel?
That's a airway device that basically kind of put down into someone's mouth that creates a better pathway for the airway.
It's what they call a blind insertion, isn't it?
Yes.
What does that mean?
It means you just insert it without, you're not looking at its placement in the mouth. It just goes into the mouth and then kind of lodges to create a seal with the airway.
And then when this process first starts, before the eye gel goes in, what happens? As far as breathing?
Usually we'll put supplemental oxygen on them, like a nasal cannula. It just has oxygen delivered to the nose, and then a bag valve mask, which is a bag that's connected to a mask that we place over the mouth, and sometimes a OPA is placed, which goes into the kind of holds the tongue out of the way while we're doing the bag valve mask oxygen treatment.
Now, if someone's operating the bag valve mask, that requires both of your hands just to make the seal.
Yes.
Can you kind of demonstrate with your hands how that occurs?
Usually it's kind of over the mouth and nose of the person, and you're putting pressure down on the mouth and nose to create a seal with the bulb of the mask against the skin
Okay.
around them.
And then
Nose
what
and
are you
mouth.
doing with the rest of your hands?
Well, if you have two people, you can have one person with two hands on the mask and another person squeezing the bag. If not, you have to just kind of use one hand to hold it the best you can and squeeze the bag with your other hand.
Okay. And I see you're sort of making your hand like that. Is that the EC grip?
Yeah.
Okay,
Yes.
That's the C and the E that comes up in the middle.
Yes.
So the C goes on the mask,
Yep.
and the E goes under the chin, kind of below the ear, around this way, right?
Yeah, kind of in the jawline maybe.
Okay. And you're using that as a way to kind of create some force so you can get a nice seal on the mask.
Correct.
You also have to kind of lift up on the head to make sure you have a clear airway.
Yes, usually you try to keep the head tilted back a little bit.
Okay. And because naturally, if a person's just lying flat on their back, it's going to basically kind of bend the airway and not allow a lot of passage. Is that right?
Correct.
How many calls do you think you've been on? Any idea at all?
Probably thousands.
Thousands and thousands. And sometimes when you respond to a call, you make your best efforts and they still pass away.
Yes.
It's not always clear why, is it?
No.
And you've seen people of all ages pass away under care, haven't you?
Yes.
Okay, that's all I have. Thank you. Redirect.
Briefly, is the dispatcher relying on the information the caller is giving them?
Yes.
And so that information that then you all receive from Cressa is then from the caller directly.
Yes.
And so before you arrive, it's a bit difficult then to vet the information, whether or not it's accurate.
Correct.
I have no further questions.
Recall?
No, Your Honor.
Can the witness be excused?
Yes, please,
Yes.
Your Honor.
All right, you're free to go. Don't discuss your testimony with any other potential witness. Your next witness.
Rick Burney.
Could you stop and raise your right hand? Do you swear or affirm that any testimony you give in this trial will be the truth, the whole truth, and nothing but the truth, so help you?
I do.
See you here then. Now that you're seated, please state your name in full, then spell your last name for the court's record.
My name is Rick Jensen Burnham. Last name is Burnham.
Go ahead, Counsel.
Hey, Rick, what's your current occupation?
Firefighter paramedic.
And where are you currently employed?
Camas Washougal Fire Department.
Have you always been with the Camas Washougal Fire Department?
No.
Where were you prior to that?
AMR, American Medical Response.
And what does AMR do?
They are an ambulance company. They transport people to the hospital.
And to work for AMR, what type of training did you need to receive?
I worked there as a paramedic, so I did paramedic school.
And when did you go through paramedic school?
I think it was 2008.
And have you been a paramedic since 2008?
I think it was 2009 I actually got my paramedic, but yes, for 16 years I've been a paramedic.
And have you maintained your license as a paramedic for that entire time?
Yes.
And what type of training did you receive to become a paramedic?
I think training probably started with EMT school, which was 6 months of night school, 2 days a week, and then you take a big test and you become an EMT. I took my EMT and started volunteering in the local fire department, and then while I was there I went to paramedic school. I had to take a few prerequisites at a community college before I could. I went to school in Oregon, which is a 2-year degree for paramedic. There's a classroom didactic, I don't remember how long, and then there's hospital rotations, and you do a 3-month internship on an ambulance, making sure you get the right number of calls and the right kind of calls to be certified.
What is a didactic?
Just classroom portion of the college or the training.
And what type of rotations did you do prior to working as a paramedic full-time?
The rotations were with the hospital, so you have to do the ER, OB, and the ICU, and then you practice intubations in the OR and people having surgery.
And once you have your paramedic license, did you have to maintain continuing education to keep your certification current?
Yes, you have to have so many hours of training every year, and you recert every 2 years.
And where do you typically receive that training? Is that in-house or?
It's through our medical director. We have a program called PSEP, and they put a class on once a month, and you have to attend the class and then take a test to make sure you learn the information.
And who at Camas Washougal Fire Department teaches those classes?
It's our medical director, who I believe works at Salmon Creek. Our friend is Marlon Mock.
Are you, as part of your training, are you taught to access or to assess cardiac arrest and perform resuscitation?
Yes.
And what type of training did you receive on that?
That would be started in EMT school as well. You receive CPR training to assess if someone's in cardiac arrest, if you can start CPR training or not, or CPR or not.
And in addition to CPR training, what other types of training did you receive?
For cardiac arrest,
Yes.
we have a class called ACLS, Advanced Cardiac Life Support, and it's more of what drugs you would give, an algorithm, how to treat each rhythm.
Are there other courses in addition to advanced cardiac life support?
For cardiac arrest or just in general?
Just cardiac arrest.
That's the one I know of.
And then, do you also receive training with regards to responding to seizure calls?
Yes.
And what type of training did you receive with regards to that?
I took a class in paramedic school called AMLS, Advanced Medical Life Support, and that's more of a medical call. You come and assess people having seizures and learn how to treat them.
So, were you working with the Camas-Washougal Fire Department in, I guess, December of 2023 into January of 2024?
Yes.
And are you still employed there?
Yes.
And what was your position or role at that time in January of 2024?
Firefighter, paramedic.
And now you said firefighter, paramedic. Is it just, are there people who are just paramedics, just firefighters, or is it both?
We have firefighter, paramedics, and firefighter EMTs.
But are all the firefighters required to be an EMT or a paramedic?
To my knowledge.
Or at least at Camas-Washougal?
Right.
And what was your assignment on, were you on shift on January 8th, 2024 in the early morning hours?
Yes.
What was your shift that day?
A shift, so it runs 7 a.m. to the next day, 7 a.m.
And are you all on 24-hour shifts, or how does that work?
Yeah, we're regularly scheduled for 24-hour shifts.
And once you have a 24-hour shift, how many days off do you typically have?
It depends, and I can't remember what schedule we were on back then, but now we do 24 hours on, 2 days off, 24 hours on, 4 days off.
And so back in 2024, even if the schedule is a little bit different, it's pretty much the same.
I would say it's close.
And who else was on shift with you that day?
Eric Miller, Chris Castle, and Michaela Young.
And now, is that the group that you would always be with on 24-hour shifts?
That's my shift, yeah.
And so it's Eric Miller, Chris Castle, and Michaela Young.
Yes.
And now when you get onto a shift, do you each get assigned certain roles for that particular shift?
Yes.
And what does that process look like?
The captain has a rotation. You're either on the engine or you're on the medic, and then it just rotates every day.
What's the difference between the engine and the medic?
The medic is the ambulance, so you're the person running the medical calls and transporting to the hospital, and the person on the engine drives the engine and then assists on calls.
And what types of equipment are in the engine?
All sorts of fire suppression equipment, as well as medical equipment such as an EKG machine, a med bag, an airway bag.
And what about just like the, what was the other one called? Sorry.
Med bag?
Med bag. And then about the other type of vehicle, what's on that?
The ambulance?
Yes.
So there's no fire suppression on the ambulance except for maybe an extinguisher, and then that's just all of our medical equipment, bandages, EKGs, IV supplies.
And how are those restocked?
We do a rig check at the beginning of every shift, and if we're missing anything, we restock it, and then after every call, we restock what we use.
So then at the beginning of your shift, starting, it would have been on January 7th, you all would have checked to make sure that you had everything you needed.
Correct.
And were there any other calls that shift that you all have had?
Yes.
Approximately when would that have been, if you recall?
I don't recall.
But do you recall not restocking the engine and the paramedic van?
No.
Do you recall being dispatched to a medical emergency that morning?
Yes.
And was that medical emergency, would you have been dispatched to a location in Clark County, Washington?
Yes.
What was the nature of the call as it came out over dispatch?
The call in question, I can't remember if it was an unconscious or a seizure. It was one of the two.
And so what was your role once you all received the call? Can you walk us through what happens once the firefighter paramedics receive a call that comes through PRESA? What does that immediately look like? What are you guys doing?
We throw our turnouts into the ambulance. We hit en route on our MDC. We look at the map to see where we're going, and then we respond to the call.
And what was your role then on that particular call?
I was lead paramedic on that one.
And what does that mean?
You run the call. You rotate on the ambulance every other call because we're a 2 paramedic ambulance, and that was just my turn.
What are the other roles, aside from lead paramedic, what are the other, I guess, roles?
They're listed in our charting program as driver and then other, and so the person driving the ambulance and then your engine crew is other. They're just there to assist, help.
And so, what is the role of the lead paramedic as it compares to the other paramedics or others?
Decide the treatment plan.
And why do you have just a lead paramedic instead of all of you deciding the treatment plan?
I'm not sure. We all kind of help each other. Like if someone misses something, someone else will chime in. But it's really, this is your call. This is how you want to run it. If someone says, hey, what do you think of this? Then we can adjust accordingly. It's not like I say this, this goes. It's very much a team approach.
And so, at any point did you realize before you went into the home that you were at the West residence?
No.
Did you make any observations that may have clued that this was a residence of a firefighter?
Yeah, I saw a Union sticker on a car on the way in.
What were your first, when you arrived at the residence, was the front door locked or unlocked?
Unlocked.
And what did you observe first? Or please describe how you entered the home.
I walked to the door, and I just remember yelling, where are you? And I heard someone yell, we're up here. And then I walked upstairs.
Had you ever been in that home before?
No.
So when you're walking upstairs, where did you locate the patient?
Top of the stairs, I turned left, went through, I believe, a French door. And there was a person in there that said my name and some other things. And I realized it was Kevin. And then I realized where I was.
Had you met Kevin before that day?
Yes.
And how did you know Kevin?
Through work.
And was he your battalion chief at any point?
Not my regular battalion chief. I may have worked overtime on a shift, but I'm not 100%.
Was he ever involved in any of your training or things like that?
I know he was around for some of the academy stuff, like he popped in when we were training, but other than that, not that I can remember.
And did you have a positive working relationship with Kevin?
Yes.
What were the lighting conditions in the room when the patient was first located?
Almost pitch black, very dark.
Are lighting conditions important to your work?
Yes.
And why is that?
You can assess the patient, see where they are, see what you're doing, see injuries, anything like that.
So, with it being very dark, did this impact your ability to see the patient fully?
I would say yes.
Was lighting eventually supplemented?
Yeah, someone was standing with a flashlight pointed towards the ceiling to kind of illuminate the room, and I think towards the end someone brought in some scene lighting for us to see better.
Are skin observations more difficult to assess under bad lighting?
Yes.
What about possible bruising?
Yes.
When you first assessed the patient, was she responsive?
No.
Did the patient have a pulse when you arrived?
No.
So as the lead paramedic, you're in the room now. What are the first things that you're doing on this scene and on this call?
Starting CPR.
And why is that?
Because they don't have a heartbeat, they're not circulating blood.
Was Mr. West performing CPR when you arrived?
I'm not sure. I know he was right there, and it's very possible. It was very dark.
But who immediately assumed doing CPR compressions?
I believe it was either Eric Miller or Chris Castle. I think it was Eric Miller.
And how long does each person do, like a, for lack of a better term, CPR rotation where they're doing the compressions?
So we used to do 2 minutes on and 2 minutes off, someone would take over, but now we have a mechanical device. So we'll do CPR, but if we believe CPR is done before we got there, we'll put a run on the mechanical CPR machine.
And that 2 minute rotation, why are you rotating every 2 minutes?
Fatigue. The person push on the chest gets tired, and if you don't push long enough and hard enough, you're not going to do anything.
What are some of the, and have you performed manual CPR?
Yes.
What's some of the fatigue that you experience when you're doing that manual CPR for 2 minutes?
You feel the soreness in your shoulders, your arms, your back. You start sweating, you get tired.
Do you have any shortness of breath or anything like that?
I've been breathing hard about shortness of breath, but almost like you're exercising breathing.
Sure. Was the patient breathing on her own when you arrived?
No.
And so what did you do next as far as the resuscitation measures?
After CPR was started, we then switched her to our Lucas device, which is the mechanical CPR, put her on our heart monitor, and then started ventilating her with the bag valve mask and oxygen.
And now that Lucas device, it can look pretty traumatic. What does the actual point of pressure look like? Is it like this, where it's kind of circular, or is it more like hands?
It's circular. So picture a long shaft that comes down, and then there's like a puck or a soft circle thing at the end, almost like a plunger. That's what pushes on your chest.
So what was the patient's heart rhythm when you arrived on scene?
The first or initial heart rhythm was asystole.
And what does that mean?
No electrical activity. They call it flatline.
Are there other types of heart rhythms that you're evaluating during a cardiac event?
Yes.
And what are those?
VFib, VTAC, pulseless electrical activity.
And so is asystole kind of the far end of the spectrum where
Yes.
you said it's flatline?
Flatline, yes.
And did Marcy West ever come out of asystole?
No.
So what attempts were made to try to attempt to have her come out of asystole?
With CPR and ventilation, we then put a breathing tube, a supravalvular tube in the back of her throat to ventilate her better. I started an IV. My partner Eric also started an IV. And then we gave her a medication called epinephrine to try to stimulate her rhythm.
And would that IV, where would that IV have been placed?
The one I placed on her would have been on her right AC, if I remember correctly. It was her left AC, and Eric was the right AC.
Would it refresh your recollection if I showed you a copy of the report?
Yes.
Showing opposing counsel what's going to be marked for identification purposes as P39. Presume witness will be the same. So Rick, I'm going to show you this patient chart. Let me know if you recognize it.
I recognize it.
Okay, and so look through that, and then once your memory has been refreshed as to which side you did IV, let me know, and I'll retrieve that document from you.
Okay. I got it.
So Rick, did you have any difficulty inserting the IV?
No.
And what side would you have inserted the IV on?
Left side.
And so when you're inserting the IV on the left side, what is the purpose of epinephrine?
Kind of stimulate a heart rhythm, try to get something other than asystole.
And now, when you're using that epinephrine, did she have any response, positive response to that epinephrine that you were able to observe?
No.
So how many rounds of epinephrine or resuscitation events did you all attempt?
We gave 7 rounds of epinephrine.
And is that more than the normal course?
Yes.
What is usually the normal course of how many rounds of epinephrine you all have?
So if it was someone we didn't know or wasn't related to one of our coworkers, we would do 3 rounds of epinephrine. If they maintained an asystole, we would pronounce them dead.
Are paramedics permitted to independently decide when to stop resuscitation efforts?
Currently, yes. Back then, no.
And so back then, who would have independently decided whether or not to stop resuscitation efforts?
I called what's called medical control and spoke with the doctor, let them know what we'd done, what the heart rhythm was, and they gave me permission to give one more medication, and if there was no improvement, to pronounce her dead.
What was that other medication that was attempted?
Sodium bicarb.
And what does sodium bicarb do?
When you're in cardiac arrest, your blood gets acidic, and your body likes to be at homeostasis, and so it helps kind of bring your blood levels back to normal. See if that can simulate a heartbeat as well.
And after consultation, were resuscitation efforts ultimately stopped?
Yes.
I don't have any further questions.
Cross-examine.
Thank you, Brandon. Morning, Mr. Brennan.
Good morning.
Now, you guys went above and beyond in this case, didn't you?
I feel so, yeah.
Normally, how many rounds do you do in a case like this?
It would be 3 rounds of epinephrine.
Okay, and how many did you do in this case?
To my knowledge, the chart says 7.
And the only reason you stopped was because you called Dr. Mock. Was that you who made the call to Dr. Mock?
No, the doctor's listed in my narrative. I don't remember the name.
Okay, all right. But the doctor who tells you, call it off or go another round.
Right.
In fact, in this case, the doctor told you to go one more round and then call it, right?
Correct.
Now, there's all kinds of seizures, aren't there?
Yep.
I mean, seizure is just a condition. It's just a manifestation of brain activity or no activity or something like that. Is that your understanding?
Sure.
Okay. Well, I mean, there's epileptic seizures. You know that, right?
Yep.
You're familiar with seizures related to blood sugar and so forth?
Sure.
Now, by the time you get to a scene, usually, if it's a seizure call, usually the seizures resolve by the time you get there. Is that correct?
In my experience, the majority of the time, yes.
Okay. And so you don't really know what the seizure looked like before you got there.
Not always, no.
You try to talk to family or anybody else who's there to find out what they saw, right?
Right.
Now, are you familiar with what's called a hypoxic seizure?
Yes.
What is that?
We don't have enough oxygen in your brain and your body seizes.
Okay. And so it could be like a person's, I guess, last movement sometimes, is that right?
Sure.
Okay. Well, if they don't have oxygen, then the body goes into a seizure-like condition. If nothing changes, they'll pass away, is that right?
Correct.
Now, so seizures sometimes they have a known cause or expected cause, right?
Yes.
And sometimes it's just random. Nobody really knows.
I would hope a doctor would know.
But you don't. But your understanding is sometimes seizures can occur that are unexpected.
Yes.
The Lucas device you're talking about. You say that she was asystole when you got there, right?
Yes.
And asystole the entire time.
Yes.
And the Lucas device, that's that mechanical CPR, which gives you time to do other stuff and keeps you from becoming exhausted, right?
Correct.
And it does a good job.
Yes.
It's very, very forceful, isn't it?
As far as I know.
Okay. You've used it, correct?
Yes.
You never had it used on you.
No.
You haven't put one on those just to see how it feels?
No.
Why not?
I don't think it feel very good.
Okay. And part of the purpose is to keep up what's called thoracic pressure.
Correct.
What's that?
The pressure inside your thoracic cavity, the higher the pressure, the more likely you are to get heartbeat back.
Okay. So is it creating a pretty high pressure, like a pretty high thoracic pressure?
I would say as normal CPR would, but it doesn't stop the pressure. So normally when you're doing CPR and you stop, that pressure comes down, or if you get fatigued, it comes down, and that kind of just maintains it.
But it increases the thoracic pressure in bursts, doesn't it? Like every time you push, you increase.
Sure.
So push, push, push. The harder you push, the more pressure, the more thoracic pressure you get.
Yes.
So the Lucas machine is designed to work for about 2 minutes and then hit a tone and then you stop.
Correct.
And that gives you a chance to look at the heart monitor and so forth.
Yes.
Now, sometimes on a call, wait, strike that question. Before the Lucas came out, were you a firefighter, EMT, paramedic?
I was a paramedic.
Okay. And so you know the days of manual CPR.
Correct.
And when you did manual CPR, you had heart monitor at the same time, didn't you?
Yes.
So that technology goes back a ways, like to the beginning of your career.
Yes.
And so you'd have a chance to kind of look and see what you're doing, maybe stop for a second and take a look to see how the heart monitor is doing.
At 2 minutes.
Yeah.
Yeah.
Why do you stop every 2 minutes?
AHA trains us that way. You do CPR for 2 minutes and then you assess for a pulse.
Okay. And I'm sorry, assess what?
For a pulse.
For a pulse.
Mhm.
Okay. And but it's possible, or at least in your experience, sometimes you'll get a pulse back, won't you?
Yes.
Hopefully that's what you're going to do, right?
Correct.
And that's the whole goal of your efforts.
Yes.
And there are times though when you get a pulse back and then it goes away again, doesn't it?
Yes.
And sometimes you'll work, you'll get a pulse back, and then it'll stop, and they don't survive the action. Is that right?
Yes.
If the pulse starts while you're doing your 2 minutes of chest compressions, you're not going to know it unless you stop and take a look, right?
Correct.
Because either your hands or the Lucas device is simulating that on the monitor, so you can't tell what's natural or what's from the Lucas device.
Correct.
And the Lucas device, like I said, it's a fairly effective machine.
To my knowledge.
Okay, you don't want to get under one yourself just for fun.
Nope.
Okay, because they're known to cause damage, aren't they?
Just like normal CPR, yes.
Okay, break ribs,
Right.
and you want to avoid using it on quite elderly people if you can.
There's a weight and size limit, yes.
Okay, what is the weight and size limit?
I believe the weight's over 600 pounds. I don't know what the height is off the top of my head.
Okay, I see. But in the elderly, because they sometimes they have what we refer to as brittle bones, it can just break all the ribs, can't it?
Yeah. But
You say that you use epinephrine and sodium bicarbonate, correct?
correct.
And did they go through the same IV?
I believe those ones did, yes.
Okay. Is it possible that there were two separate IVs put in this case?
There were 2 separate IVs in this case.
Okay, who put the other one?
Eric Miller.
Oh, all right. When you first saw Kevin, and I kind of forget, when did you realize it was Kevin's house?
When he said my name.
Okay. So that when you got to the top of the stairs and looked in the door?
Yeah, when I was in the room, I believe.
Okay. I know you're reluctant to say it, but it's okay. What did you say?
What the fuck, Rick? This is so fucked, or something to that offense.
Okay. And how was he behaving?
Hysterical, crying.
Had you ever seen him like that before?
No.
No, when it was, yeah, strike that. I'm going to come back to that. Now you have seen situations where people do appear to be having a seizure-like activity in front of you, correct?
Correct.
And you've seen them transition from that into a condition that is known as cardiac arrest.
Correct.
And you explained something about, I'm going to say it wrong, VTAC, VFib, am I close?
That's right. Yeah, you nailed it.
Okay, what are those?
Those are heart rhythms. So ventricular tachycardia or ventricular fibrillation. It's your heart's beating at a weird rhythm that's not sustainable. And I guess with the seizure part of it, what I've seen is people that go into that in front of me have had a slight seizure and then have gone into that rhythm.
Okay. And you've seen people go into that seizure-like condition, go into cardiac arrest, and then pass away from it.
Yes.
Now, you say that when person is asystole, they're not breathing, of course, they're not getting any oxygen, right?
Correct.
And that's also known as the flatline condition.
Correct.
How long can a person remain in flatline condition and still be revivable? Do you know?
No,
Is it a pretty short amount of time?
I don't know the answer.
Okay. You guys are in a hurry when you do these jobs, aren't you?
Correct.
You get the bell, you get out of bed,
Yep.
put on your pants, get your spotted dog, you get in your cars and you go, right?
I wish we had a spotted dog.
Okay. No spotted dog, but you go as fast as you can because every second counts.
Yep.
In this particular case, Michaela was doing the airway, right?
Correct.
Is that also referred to as bagging?
Yes.
Okay. And that's the bag valve mask and the I don't know what you call the squeezing part. What do you call that part?
Bag valve, the bag, yeah.
And actually, she didn't start doing the airway until the Lucas machine was on.
I don't know the answer.
All right, that's all the questions I have. Thank you. Read the rec.
No, Your Honor, may this witness be excused?
Yes.
All right, you're free to go. Don't discuss your testimony with any other potential witness. We'll take our morning recess. Close your notepad. Leave them there in your chairs. We'll discuss the case among yourselves with anyone else. Raise your right hand. Do you swear or affirm that any testimony given this trial will be the truth, the whole truth, and nothing but the truth to help you? I do. Please be seated here then. Now that you're seated, please state your name in full, then spell your last name for the court's record.
My name is Eric Miller. Last name is Miller.
Go ahead, Counsel.
Eric, what's your current occupation?
I'm a firefighter, paramedic for the city of Camas and Washougal.
And how long have you been a firefighter paramedic?
I was hired in September of 2020, so 5 years.
And what training did you undergo to have that position?
So for paramedic, it's the required state certification. Clark County has their own lead paramedic training as well, and assessments. And then for firefighter, there's a 3-month academy that I undertook through the Department of Camas and Washougal Fire Department.
And what does that separate lead paramedic training entail?
It's a written exam, practical exam to be evaluated by our county medical director, who's a physician. Various questions on advanced life support and different life-saving interventions, medical administration, things like that.
And would you have undergone that training prior to January of 2024?
Yes, ma'am.
What certifications did you hold that were in effect on January 2024?
So I was a firefighter, paramedic. I also had certification in swift water rescue and road rescue as well.
In January of 2024, what was your assignment with the Camas Washougal Fire Department?
I was assigned as a firefighter and paramedic at Station 43 in Washougal on A shift.
And who was on that shift with you?
I was working with Captain Chris Castle, firefighter paramedic Michaela Young, and firefighter paramedic Rick Burnham.
And so then would you all have done majority or all of your calls then together because you were all on A shift together?
Yes.
And so were you on duty in the early morning hours of January 8th, 2024?
I was.
And what was your assignment on that particular day?
I was assigned to the ambulance, and so I would have been one of the paramedics with Rick Burnham.
And so who would have been in the other vehicle or the engine?
Captain Castle and Firefighter Young were both assigned to the engine.
And who would have been the lead paramedic for that particular shift?
The way that our shift works, we tend to switch who's the paramedic in charge. So we all have the same certification as lead paramedic, but when we respond to a call, one person will be the paramedic in charge, and the others would be support. And then on the following call, then we would switch roles, and then the next person would be the paramedic in charge, and the others would be support.
And now when you're kind of observing it on the body-worn camera, it almost looks a little bit like a pit crew, like with each of you having different roles. Can you explain that further?
Yeah, the idea of what we try to bring to these calls is to sort of bring order to chaos, and by having us like predetermined or assigned roles, that helps to achieve that goal, where one person would be in charge of, say, airway or ventilations, and that's their job, that's their role. The next person might be in charge of IVs or compressions or medications, or checking, running the monitor that we utilize in these calls.
And so by giving each person a different role, the goal then is to then reduce that chaos, is what you're saying?
Correct, yeah.
And what was your role when you responded to the call on January 8th, 2024?
So as I said earlier, I was on the ambulance with Rick.
Or sorry, what equipment were you assigned to doing?
So initially, I would have been assigned to, it sort of bounced around on that call. Initially, I began chest compressions, and then I was assigned to an IV, as well as drawing up medications. And then later on in the call, as things progressed, and paramedic Burnham had to step out of the room to contact a physician, then I took his place as administering medications and looking at the monitor and calling out rhythms that I saw there.
So what was the initial nature of the call that you were dispatched to?
Initially, we were dispatched to a seizure, and then it quickly, I believe even before we left the station, it updated to cardiac arrest.
So when you get a call for a seizure, what are you thinking? What's it going on in your mind as to what you might be responding to?
So if we're responding to a seizure, I would say, we're thinking of potential treatments that we're going to be needing to prepare to administer, whether that's airway control or if it's oxygen administration, or if there's medications that we need to be drawing up and administering to stop that seizure. We're also trying to think of what may have caused that seizure. If this is a known, like a person with a known seizure disorder, or if this is a first-time seizure, what could be the cause for that first-time seizure?
And so, what are potential causes of first-time seizures based on your training and experience that you are aware of?
First-time seizures could be, that could be either the development of a brain tumor. It could be related to, issues with, like a diabetic may have seizure-like activity if their sugar levels deviate too far out of their normal range. We could be looking at massive trauma or brain injuries. Hypoxia is another one, which would be lack of oxygen to the brain, or some sort of like catastrophic medical event, either like an aneurysm, a fatal cardiac dysrhythmia, So these are the things that we would be at the forefront of my brain when we're responding to these calls.
You mentioned fatal cardiac dysrhythmia. So is that something that, in your experience, can be first and then lead to what looks like a seizure? Or
Yes.
maybe not?
Yeah, I would say so. There's a difference between a true seizure, which would be a neurological issue with the brain, right? And then what appears to be seizure-like activity. That could be due to which would essentially look like a brief period of tremors, but it might be localized either to just upper extremities or maybe even just the head or face. And that could occur with when somebody faints. That could occur with these fatal cardiac dysrhythmias. Essentially, it's like a quick lack of oxygen or blood pressure to the brain that would cause these tremors and someone to either pass out or expire or die.
And so you mentioned that there's like true seizures and seizure-like activities. Do you ever respond to calls in your training experience where people will call thinking they've seen a seizure and it's in fact something else?
Yes, ma'am.
And can you tell me more about that?
Yeah, a common instance that we would respond to would often be somebody had, say, fainted. Right? It's called a syncopal episode, where, as I stated before, basically they could have a significant drop in blood pressure. It no longer perfuses the brain. They pass out, and then during that time of fainting, there could be observed a quick and brief moment of shaking, those tremors that I discussed.
I want to go back to the call itself. At the time of dispatch, did you know who the patient was?
No.
At what point during the response or during the call did you realize that it was Kevin West's residence?
It was after we had made contact with Kevin and Marcy that I realized what was going on. I saw a man performing CPR on a woman, and when I knelt down next to them to basically take over chest compressions, the man sort of fell back against his bed, and I saw his face, and I realized that then it was Kevin.
And had you worked with Kevin prior to that day?
I had.
Was he ever your captain or battalion chief?
He was my battalion chief for the previous 2 years.
And so, with him being your battalion chief for 2 years, did you work with him quite a bit?
Yes. So I believe that Battalion Chief Silva went over how our department is structured. The battalion chiefs tend to, they're housed out of the downtown Camas station, and I'm at the Washougal station, which is the next town over. Battalion chiefs would often come by each station to see how crews are doing, what the training plans were for today, if there were any specific needs for equipment or training or anything like that. They would also respond with on bigger incidents, whether they were fire incidents or rescues of any kind, or car accidents, things like that. So,
And are those high acuity calls that you're referring to?
yeah, it'd be a high acuity. It would be anything that required lots of manpower, lots of personnel, and the battalion chief's job is to essentially manage all of the resources that are there. They can assign the tasks to perform the objectives needed to complete either the rescue or fire extinguishment or cut somebody out of a car if they're on the highway, things of that nature.
And so when you first arrive and you observe Kevin performing chest compressions, what did you do next?
So I took over the chest compressions on Marcy, and then quickly after that, Captain Castle and Firefighter paramedic Young arrived, and then we placed the Lucas device on Marcy to take over chest compressions for us. And then Michaela would have gone over to toward the head of Marcy to start start ventilating with the bag valve mask.
And so how long approximately were you doing chest compressions, do you think?
Myself personally,
Yes.
15, 20 seconds, and then Captain Castle took over chest compressions so that I could prepare the Lucas device.
And what does preparing the Lucas device involve?
So the Lucas device is essentially two main pieces. You have a flat curved back plate, and then you have the main body of the Lucas device, which looks like it's a big arch and with the center pivot or plunger. So to apply that to someone, you would have to either roll or lift the patient to place the backboard underneath them. You set the patient back down on top, and then resume CPR, manual compressions. And then a second person would then connect the Lucas device from those wings that come down on the arch. They would connect to the back plate on either side, and then lower the plunger and press the button, and away it goes.
And now when you are, for lack of a better term, like moving or manipulating the patient, how are you doing so? Are you making sure to do so carefully, or what's going on there?
Yeah, we're trying to be careful. We have to, and especially in Marcy's case, Marcy was not a large person, so I was able to lift her forward, and essentially, so she was almost in a sitting position, where we could then apply the defibrillation pads, both anterior and posterior, so on her back, place the back plate underneath her, and then set her back down on top of it.
And what's the point of putting the defibrillator pads on at that time?
So the defibrillator pads would provide a readout on the cardiac monitor. It would be able to tell us what kind of rhythm she was in, and then they are also capable of administering a defibrillating shock. If you see it in medical dramas on all the time, right? When it's essentially the paddles that the physicians on, George Clooney on ER would administer, right? So it has the dual purpose for that, where it could both provide us live cardiac information or rhythm information, but also give that defibrillating shock.
And now, what was the heart rhythm that Marcy was in when you all arrived on scene?
So it's called asystole, which is flatline.
And now, throughout the body-worn camera of her resuscitation efforts, I don't see that shock happening. Why isn't that being done?
So flatline or asystole is what's called a non-shockable rhythm. The idea basically is that any sort of shock to that heart would not cause any change. Right? There's zero electrical activity happening at the time. There's zero muscle function happening at the time, so no contractions or at least no spontaneous contractions in that heart. So there's nothing to shock.
And so after you did the application of the Lucas device, what was your next role that you were doing within the resuscitation efforts?
So after that was in essentially a support role for a while, where I would be preparing IVs that Rick Burnham applied. I was grabbing supplies for paramedic Young to help with securing or managing the airway. And then shortly after that, I was then asked to start another IV on Marcy's right arm. And then for a while, I was there trying to kind of console Kevin And then after, as I said, when paramedic Rick Burnham had to leave the room to make a call to the doctor, is when I assumed his role of medication administration and then monitor control.
And now, if there's an IV in the left arm, why would there also be a need for an IV in the right arm when you were treating the patient?
This is a critical call. More line access, what as we call IV, is aligned, is better for us. We may be giving two different types of medications that may interact with each other. In this case, that didn't happen, but we want to make sure that we have plenty of access. If for any reason this IV fails or gets dislodged or displaced, we have a secondary backup that we can start using.
And based on your recollection of the call, were there any issues in inserting the IV or getting IV access to Marcy?
No.
And now, you did mention that you were doing some medication management. In addition to epinephrine, was there anything else that you administered to Marcy?
Near the end of our efforts, we did administer a medication called sodium bicarb. It's not a medication that's routinely used for every run-of-the-mill cardiac arrest. Starting to get into the Hail Mary ideas of medication administration. Right? The epinephrine in Marcy's case was our go-to medication. We're attempting to try to restart her heart, give her heart enough energy to start on its own again, without any success. So our Hail Mary effort was to give this medication to try and account for any acidosis or any other abnormalities that we wouldn't have knowledge to without a full lab or anything like that. But it's trying to, like I said, a Hail Mary pass, trying to just see if we can do anything to get that heart to start again.
Now, after the first round of epinephrine, did that change her heart rhythm at all?
No.
And what was her heart rhythm after the first round of epinephrine?
It was still an asystole.
And so, after that was a second round of epinephrine administered.
Yes.
And how far in between, after the first round, how much time goes by before the second round of epinephrine is usually administered?
Each, it's 3 to 5 minutes between the rounds of epinephrine. Each round of CPR is 2 minutes long. So between 3 and 5 minutes would have been every epinephrine administration.
And now, after the second round of epinephrine, did Marcy's heart rhythm change?
No.
And what about after the third round of resuscitation efforts and epinephrine?
No.
And so, after the third round, is that typically when your team will contact a physician or cease the efforts?
Typically, after 3 rounds of epinephrine with no change to an asystolic rhythm, yes, we would stop our resuscitation efforts.
And why is that?
Well, the research tends to suggest that at that length of time, without any spontaneous circulation, without any cardiac rhythm, the chances of survival start to deteriorate pretty quickly. So there's little change that is expected if any efforts were to continue, especially in the pre-hospital setting.
How many more rounds of epinephrine and resuscitation efforts did you and your team attend at that time?
I believe the video shows 8 epinephrines administered.
And did Marcy come out of asystole during any of those rounds of epinephrine or resuscitation efforts?
I believe around there is a period in the video, in the body cam video, where I had taken over administration of epinephrine in the monitor duties, that I said that there was a rhythm. I believe it was what's like an agonal rhythm, and then quickly after that, within 2 seconds after that, she had returned back into asystole again.
And is that agonal rhythm any indication that the heart is continuing to restart?
I think that's up for debate. My personal experience would be more. I'd be more inclined to say that she had received 6 to 7 epinephrines at that time, and that was just the epinephrine's only ability to create just those 1 to 2 seconds of any sort of electrical activity. In the video, when that occurred, paramedic Young was feeling for a pulse, and there was no pulse to be found with that agonal rhythm. So.
And now, is the pulse, so in the video I see someone kind of putting their hand down by the hip bone. Is that a location where you all can access a pulse, or what is the purpose of that?
Yeah, you can access an inguinal pulse or a femoral pulse down in that area. Carotid is also another location. So paramedic Young being at the airway, would have been checking for carotid. In the video, I'm the one looking for either a femoral or an inguinal pulse.
And there's no pulse that was located?
Correct.
And now, what, if anything, do you recall that Kevin is saying to you or others during this time?
I remember Kevin had mentioned that Marcy had complained of a headache prior to going to bed. I believe he had mentioned that she had vomited prior to bed as well. And then most of what I heard from Kevin beyond that was him pleading for Marcy to wake up or pull through, kind of just seeming like he was mourning with the crew that was there, mourning the loss of his wife.
Now, when you're hearing this thing of the headache and other symptoms that he's describing, based on your training and experience, what are you thinking is happening then?
My frame of mind then would have been, a catastrophic medical event, either a sudden like ischemic stroke, a brain bleed, or an aneurysm of some type. That's where I was thinking was the cause for this.
And at any point during the call, did Kevin mention to you all a history of seizures for Marcy?
He did not. He specified that she didn't have any medical history.
Based on your training and experience, is it common for a first-time seizure to occur for someone in their 40s?
I object as the foundation.
Any further questions?
Cross-examiner.
Thank you, Connor. Morning, Mr. Burnham.
Mr. Miller?
Mr. Miller, sorry, but we just had a Burnham here a minute ago. So this, the call on the morning of the 8th, was at the end of your shift?
It would have been 3/4 of the way or so through the shift, yeah.
What were your hours that day?
We work a 24-hour shift from 7 a.m. to 7 a.m.
Okay, so the call comes in a little after 4:30, something like that.
Yeah,
And so, but you were just returning from a call at that time, weren't you?
correct.
In fact, you hadn't even gotten out of your truck when the call came.
I don't recall if we had or hadn't, but I do know that we were still in the ambulance bay, in the truck bay.
Okay. So when you got back, did you have to like reload, restock, or anything like that?
Not reload as far as medications or anything like that. If we had gotten out of the ambulance, then we would have taken our fire gear off and staged it for another response. So we may have had to put our gear back on, but as far as medications or other medical equipment, we didn't have to restock anything.
You didn't go like in the station, like sit and have a cup of coffee just for a break before you went?
No, sir. No,
This is pretty important stuff, isn't it?
absolutely.
Absolute urgency. Correct?
Yes, correct.
Now, when you got there, you say that the person you saw, you didn't know who he was at first,
That's right.
but the person was doing chest compression.
Yes,
Did he appear to be doing them proficiently?
yes.
Did that surprise you when you got in that this person knew how to do chest compressions properly?
It did, yeah.
Then you realize it was Kevin,
Right,
then no surprise.
right.
Now, when you got there, you say that she was asystolic, correct?
Correct.
Or you say asystolic, don't you?
Yeah.
Okay. And I'm not sure which way is the right way to say it. I kind of go both ways. And so you don't know how long she had been that way.
No.
Kevin remained in the room on her side, and that's a little unusual for a person who's not involved in the life-saving team to stay in the room, isn't it?
It may be. I think that's up for debate as well.
Okay. But there was room for him,
There was.
and he wasn't getting in the way.
No.
Didn't try to interfere.
No.
Didn't try to call the shots.
No.
Now, you talked about the eye gel. You did not do the eye gel insertion in this case, correct?
I did not.
Okay. And it's, I'm showing you something that's not been marked as an exhibit just yet. But this is, says 50 to 90 kilogram eye gel, non-latex. Let's see. Okay. So this item that I'm showing you looks like it's about 9 inches long, got kind of a green rubber part top. You want to take a hold of that?
Sure.
Does that look familiar to you?
Yes, sir.
I'm going to object that this is outside the scope, and this witness was not the one who placed the eye gel.
Overruled. And is this similar, I know it's not the one you used, but is it similar to the one that was used in this case?
It is similar.
Okay. And how, is it different from one that you typically stock at your fire station?
No, it's not different.
Okay. So using that just for demonstrative purposes, how does that go in?
So this is what's called an SGA, a supraglottic airway device. The way that you would insert this into someone would be, I'd be sitting at their head. I would open the airway, either with the head just like tilting the airway. I'd need to control their tongue. So I would grab their tongue and the bony part of their jaw, and then open it, kind of pin the tip, almost like a tongue depressor, right? And then the curved part here would follow the roof of the mouth, and then you would just insert this until you met resistance. And what that resistance would be this cup piece would be sitting over the trachea, which is the tube going into the airway, into the lungs.
Okay. So, I mean, just looking at it, it looks like it would go kind of curved under down the throat, but it actually goes the other way.
Right, yeah, so if, I'll use myself for
If I actually,
demonstration.
hold
Okay.
on a second, I got one more thing. Help us here. If our little friend behind with me. This is actually a CPR dummy. It is a Preston Industries CPR dummy. That's a female. And have you seen this kind of dummy before?
Yeah, I don't know if I've seen this exact one before, but yes, I'm familiar with these styles of training dummies.
Okay, so using that dummy, I don't know that you can actually fit that into the mouth, but how would you insert it, just kind of demonstrating from the side?
Sure. So from the side, like I said, normally what I would prefer to be would be this direction. But what you would do is, like I said, you would do a little bit of a head tilt the head a little bit, and then insert finger to grab the tongue, and then like bony prominence either on the jaw or the chin, and then this would go in from like basically following the curve of the roof of the mouth. You'd go in like this, and then, like I said, until you felt resistance, you know that you've got a good seat there, or a seal, and then this tube would be coming out of the mouth like so. You'd attach your BVM and oxygen there, and you'd be able to ventilate the patient's lungs through that.
So where you once had, let's say, the mask hooked onto the valve that you're squeezing, the valve comes out and the tube goes onto that. Is that correct?
The mask portion comes off. Yeah, the mask portion comes off, and then this is inserted, and then that bag goes back on so that you can squeeze the bag.
So this goes in this direction or this direction?
It would go in this direction.
Okay, so it goes in curve side up, I guess, all the way down here. How much is sticking out of the mouth at this point?
Generally, you see this black line right here?
Yes.
That black line would be where try to aim for where the teeth would line up with that black line.
Okay. And then when you use the eye gel, let's say you've used an eye gel in a situation where a person has passed, correct?
Correct.
And what's the routine when a person passes and they have an eye gel in? Do you leave it in?
Generally, we leave it in.
And was it left in this case?
It was not.
Why is that?
Kevin requested that we remove the eye gel, and out of respect for him and for our, we had no reason to believe that any of us would be sitting here today. We elected to remove it.
Well, sure. And his son was on the way to see his loved ones.
That's right.
And so it was removed. When you first put it in, do you take any precaution to make sure that it can slide in at all?
Usually there's some lubricating jelly that we would apply to the back of the device so that it would slide along the roof of the mouth easier.
Now, in this case, it appears from the video that you've mentioned from the discussion that the eye gel was in for quite some time, wasn't it?
I think that's fair to say, yeah.
Maybe 25, 30 minutes, something like
Right.
that? Okay. Is there any additional lubrication going down, squirting something down the throat or whatever to make sure it stays lubricated down the throat while this process is going on?
No.
Okay, I'm going to take this away for just a minute here. Now, when you got up there, you noticed the person doing compressions and the body on the ground, correct?
Correct.
And you were actually the very first person in the room, weren't you?
I was the second person in the room.
I'm sorry, because Rick Burnham was in there first.
That's right.
And when you got in there, you noticed, the only thing you noticed near her was a nightstand by the bed, correct?
I don't recall anything near her. I'm not saying that there wasn't one. I just don't recall there being anything near her.
Okay, I'm going to come back to that in just a moment.
And I'm not sure whether we covered this or not, with the eye gel, that's what's called a blind insertion, correct?
Right. The technique to insert it is it's referred to as a blind insertion.
Can you describe how your hands are placed on the person's face or jaw or whatever while you're putting that in?
Sure. So like I said, what we would do is we would tilt the patient's head to kind of elevate their chin a little bit. You'd either do that by just moving it with both hands on the side of their head, or if you're able, you could just put your hand on the back of their head and sort of scoop and push forward. And then you open the airway with one hand, and then, like I said, you would grab the tongue, try to pin it against the bottom part of the mouth or the jaw, and then you would grab like a bony area, either the chin or the jaw, to try and keep that tongue and airway open while you inserted the device.
I'm just going to go back for a second here. I'd asked you about the nightstand. Do you remember talking to me back on October 10th of 2024, roughly?
I recall the conversation took place, yeah.
Okay, you recall that I was recording, remember?
Yes.
Okay. And I'm just... I didn't give you the whole thing. Can I attach this to the back? This other half that I missed. Sorry. Technical difficulties. Sure. 1 second. So you mentioned that you used, you were the person who brought the Lucas device up on the backpack, right?
I believe so, yes.
Okay. And so you kind of described how it's attached and so forth. I'm going to bring the CPR dummy back here for just a second. Also going to bring you another item here. This is titled Lucas It's called a type is called a backplate complete 100-179-00. Let's just take a look at that. Have you seen something similar to this?
Yes, sir.
And what is that?
So this is not the exact one that we have, but it's very similar. I'd say it would serve the same purpose, especially same brand and everything. This is the backplate to the Lucas device.
Is that the same size and shape?
I would presume so.
Okay. You've never compared two side by side?
Presume things. If you don't know something, the answer is you don't know.
Yes, sir.
Does it look the same?
It appears the same.
Okay. And so, can you just show the front portion, just kind of explain the parts to the jury and what they're looking at on there?
Yeah. So this is the curved backplate. Obviously, it has a curve here. This side would be the side that contacts with the patient with their back. This side would be on the floor or ground, wherever you might be. These two pieces here are just metal of some kind that would attach to the arch of the Lucas device itself.
Okay. And so the arches snap onto those poles, is that right?
That's right.
Okay. And what's the picture that we're looking at, that diagram, what is that?
This shows the placement of where the backplate should be. It's difficult. I'm sure it's difficult for you folks to see, but this is a picture of just a person, and on either side of it, underneath the armpits, are where the two posts for the Lucas attachment arch would be located.
So does it kind of squarely tuck right up into the armpits, basically?
Yes.
Okay. And it's under the backside. And is it directly beneath the arch where the plunger's coming down?
Yes.
Okay, so if the person weren't there and the plunger came down and made contact with that plate, where would it touch?
It can't touch the plate.
But where, if it could, where would it, if it continued on its journey, where would it hit?
It should, right there where the little target direction or symbol would be.
Okay. Now, is there a direction to that? Is there an up and a down?
No,
So does that target appear to be right in the center of the plate?
it appears to be so.
Okay. Can you just kind of demonstrate the placement under this dummy? I'll get this back in just a second.
All right. So this would go, like I said, we would lift this patient or roll, and then the plate would go right here, tucked up underneath. This dummy doesn't have any arms, obviously, but it would tuck up right underneath their armpit.
Okay. And of course, a person is softer, more pliable, and tuck right up under the arms, right?
Sure.
Okay. And then, can you point out where the plunger should come down?
Yeah, the plunger should come down at the bottom third of the sternum, near the bottom of the sternum, basically right along the nipple line of this dummy here.
Okay, so right, using that as a line right in between on the sternum, that's where it would be centered?
Yes.
Okay. Now, ordinarily there's a neck strap involved, correct?
There is a neck strap that comes with the kit. Yes.
Okay, and it's something that hooks on both arches, goes around the neck, and then keeps the device from moving around.
Right. It's a stability strap. It helps to prevent any like downward drift of a device.
Okay. Okay. So I'm going back to my earlier question. We had talked about the fact that I talked to you back in October of last year. And I asked about whether or not you'd see a nights. This has been marked as defense exhibit 3 by 3. I should show it to you. It's page 16. Now, Mr. Miller, I had asked you if you'd noticed any furnishings in the room, okay, and you had given me an answer. Do you recall what that answer was sitting here today? I know it's been almost a year and a half.
Right. I don't.
If I show you the transcript or discussion, would that refresh your recollection?
I think so.
Okay. Why don't you read from right about here down to, let's say, 9 down to 20.
Okay.
Okay. When you're done, just let me know, and we'll ask you more questions. Okay.
Okay.
Does that refresh your recollection?
Yeah.
Okay. And so I had asked you if you noticed any furnishings next to the bed. What did you tell me?
In the transcript, it says that I recall a nightstand next to the bed, as well as some type of like a dresser or some piece of furniture similar to a dresser near the master bathroom by the foot of the bed.
And the nightstand was next to the bed. Where was it in relation to Marcy, according to what you told me back then?
It would have been on the same side of her as where she was, so near against the wall where her head was closest to, I suppose.
Now, it's a common practice, is it not, when you get to a scene, if there's limited space or it's just not an ideal situation, you're either going to move the patient or you're going to move things out of the way, aren't you?
Yes, that's common practice.
And usually that's going to be the first people on the scene, or at least within the first few minutes, people are clearing the scene, correct?
Yeah. If we can, yes.
If you can, right?
Yeah.
Now, in this case, Michaela Young came in and she did the airway, right?
That's right.
Okay. But she had not done the airway until the Lucas device was on. Is that your recollection?
I believe so.
Is that pretty common to not have the airway started until the Lucas is on?
I would say not necessarily common, but oftentimes CPR is going to be initiated before an airway is in place most times.
Now, for CPR, there you talk about airway, you talk about compressions. I think that all of us who went through high school when they were my age, we were taught to do a couple breaths and a bunch of compressions. What is the current practice?
So for us, CPR is a combined effort, right? Where you're doing chest compressions to get blood flow, right? To manually contract the heart to get blood flow through the body into the brain, and then ventilation with oxygen. Those two can basically work together to try to keep tissue and organs alive.
No, go ahead.
All right. CPR or the chest compressions for folks out of hospital or out of without much medical training. The chest compressions is the real important part because it gets blood flowing, and so whatever residual oxygen may be available in the blood can still get delivered to those tissues.
So a person without equipment who's just out in the field and they're doing CPR on their own, if they're doing the compressions and then putting the breath in, is the breath providing oxygen, or what purpose does that serve?
You're talking like mouth to mouth?
Yeah, just a regular person, like if I were to go out in the hallway and do this and I don't know what I'm doing, what would that purpose serve?
They're still training that way as far as I know, like in basic first aid classes, CPR classes, things like that. But the reason we use oxygen in a bag valve mask is because it's more sanitary. We're not putting our mouths onto the mouths of strangers, but also it's actual oxygen. What we exhale is predominantly carbon dioxide. So probably trace amounts of oxygen that would be beneficial to someone in need of it. But we have on the ambulance we have the equipment to provide 100% oxygen.
In the case of a seizure, it's common that seizures have resolved before you get there on a seizure call, right?
Yeah, that happens.
Okay. But you have seen people go into a seizure-like condition and then go into cardiac arrest in front of you, haven't you?
I don't recall having any cases where that's happened, but personally, it could certainly happen.
Now, when you're putting the bag valve mask together and you're trying to get a seal, you're putting the Lucas device on, you're trying to be careful because it's a human being, right? Mm-hmm. Is that yes?
Yes.
Okay. But your primary concern isn't for their makeup, their lipstick. I mean, these are life-saving, last-ditch Hail Mary efforts, aren't they?
Right.
So the actual comfort of the patient is not the top priority. It's kind of a balancing act, isn't it?
Yes, with an asterisk, I suppose. Right. I mean, CPR is not a pleasant intervention. Right. It's not a gentle sport, so to say. Right. The alternative of not performing these interventions correctly or efficiently would ultimately be death.
Right. Yeah. And the Lucas device itself can break ribs, can't it?
I think it can, yes.
In fact, regular CPR can do that if you're not careful.
It can.
Even if you're careful, it can happen.
It can.
You said that, I'm not quite sure I heard you. You said you implied that a person would have a better chance of surviving this kind of event in a hospital. Did you say that?
That's not what I said.
Okay. You said something close to that.
I said that something to the effect of the administration of 3 epinephrines with no change in an asystolic arrest tends to have negative outcomes, or poor survival. I said particularly out of hospital, mainly because in most cases, out of hospital cardiac arrests occur without being witnessed. They occur without like bystander CPR. And really, when we arrive, when we get called to a cardiac arrest, most times we're already behind the 8 ball. Right? This is a time-sensitive event, right? And the sooner you can get CPR initiated, then the better the outcome is.
Now I think you mentioned that the lighting in the room was not good.
That's right.
Dark.
Dark.
Okay. There was, some rope lighting in the ceiling, something like that?
I don't recall the exact type of lighting. I do know that whatever it was controlled by a tablet or some type of remote control that was not working appropriately.
Okay. Now, why is having sufficient light important? When it's all hands-on work, why is having light important in a case like that?
We want to see what we're doing. We want to see that we're grabbing the right size IV, that we've got correct placement of our, that we can start an IV, right? That we can actually see or feel what we're looking at. We can see that the IV was successful. We can see that the IVs are running without any hindrance. I mean, it's a hands-on game, but vision's very important too.
Absolutely. So you're when you're trying to see if somebody's breathing, what are you looking for?
We're looking for chest rise, essentially, right? I mean, you're looking at their face to see if their mouth is open, if there's any signs of breathing there. We're feeling and looking at the chest to see if there's any movement in the chest or abdomen, if they're using their diaphragm.
Okay. And in a chest rise, I mean, that's something you need lighting to see, obviously.
You can use your hand to place on the chest.
And then you're going by feel.
Right.
Have you ever checked for breathing on someone who's in a seizure condition?
Yes.
Okay. Is it harder to tell if they're breathing if they're seizing?
It's harder, but it's not impossible.
Okay. But if you can't see and all you're working by is feel, does it make it harder?
It would, yes.
You also mentioned that there was a rhythm detected. You said agonal, you said?
Agonal.
Agonal. And that happened after how many rounds?
I don't recall how many rounds. I believe the timestamp was about 5 a.m. on the call.
So about 10 minutes before she passed?
Right.
So there was something there. You think it might have been because of the epinephrine, correct?
Correct.
But you don't know that for a fact.
I do.
Could have been the heart trying to restart and just not being able.
I don't know.
But that is possible, right?
I suppose.
As a person who provides this kind of service, sometimes you do like a weekly review, is that right? Or you'll...
Objection outside the scope of draft.
I'll allow the answer as to whether it does a weekly review sometimes.
Do you sometimes do weekly reviews of cases? Or after the fact reviews?
Yes.
Okay. But you don't follow every case up to the hospital, to the medical examiner's office. You don't always know what happened down the road, do you?
We don't.
In fact, most of the time you don't, do you?
Objection outside the scope of draft.
Most of the time you don't know, do you?
No, we don't.
Just one quick follow-up on the IGL question. Where it makes it seal, where does it end up? I'm not quite sure I was real clear on that. What part of the body inside does it make contact with?
So that scoop part, the green part on the eye gel, would come into contact with what's called the glottic opening. It sits over the trachea, and then it would seal there.
Okay, can you kind of explain how that relates to the esophagus? Which part is the esophagus? Where is that in relation to the esophagus?
So, yeah, two tubes, right? There's the trachea that goes into the lungs, and that sits, if we're using me as an example, that would sit forward of my esophagus, which is in the back, right? And that's the tube that goes down to your stomach.
Okay. And so this one goes down which tube?
The trachea,
Yeah.
so it would go down to the lungs. And
Okay, and that's where the eye gel goes?
the eye gel covers the opening to the trachea, yes.
Okay. Okay, I think that's all I have. Thank you very much.
Redirect?
Yes, please, Janet. So, Eric, would the body-worn camera be a more accurate reflection, perhaps, than your independent memory of the resuscitation efforts?
I think that's fair. I mean,
And while you are all conducting the resuscitation efforts, is there also a chart or medical record that's being created contemporaneously?
yes,
And is that the patient care record?
it is.
And would the patient care record, that be probably the most accurate recollection of the care of the patient?
Yes.
And you talked on cross-examination about some furniture, a nightstand. Do you recall yourself moving a nightstand at all?
I did not.
And so you didn't move a nightstand from the side of the bed into a attached closet.
I did not.
Did you observe? And you were kind of the person assisting, and Rick was the lead, correct?
That's correct.
Do you recall observing Rick moving any furniture?
I do not.
Do you recall seeing Michaela moving any furniture?
I do not.
Do you recall seeing Chris Castle moving any furniture?
No.
Now, on cross-examination, you also mentioned that these are time-sensitive events, correct?
Correct.
And that when you got to the scene, you saw that someone was performing CPR correctly.
Yes.
And why is it helpful to that someone was performing CPR correctly prior to you all getting on scene?
So when a bystander initiates CPR early on in a cardiac arrest, the chances of their survival increase substantially. And that's recorded through several trials and studies over the years. And so, especially from a trained medical professional, that should speak volumes. That should increase the chances of her survival.
And so, to your knowledge, based on the call that you all received and the information from dispatch, resuscitation efforts would have began almost immediately.
Yes.
And that should have improved the likelihood of the outcome.
It would give her the best chances, yeah.
And now on cross-examination, he brought up the lighting of the room and the condition of the room. Were you and your team still able to effectively do your work on the patient regardless of the lighting?
Yes.
And are there other situations in which you'll respond to patients and the lighting will be poor there?
Yes.
Does bad lighting prevent you from doing your job entirely?
No.
Are you all doing this enough that you have a little bit of muscle memory as well?
Yes.
And now on cross-examination, he also brought up, I'm going to grab this study as well. Now, did you observe that, based on what you were looking at, any injuries or forceful movements to the patient's neck at that time?
No.
And now the eye gel strap, that was not on the patient either.
The iGel
Or
strap?
sorry, not the Lucas device strap was not on the patient either.
Correct, it was not.
And so, but the strap being on prevents it from moving downward, correct?
Yes,
Not upward.
that's right.
Did you observe anyone else except for the 4 people responding moving any furniture at that time?
No.
And did you all have, while a confined space, enough space to effectively do your work?
Yes.
I don't think I have further questions, Your Honor.
Reed Crowe?
Just a quick follow-up. At some point, Mr. Miller, lighting came in, correct? Somebody with lighting came in?
Yes.
Okay, and that helped you with your job after there? You're able to see better?
We are able to see better, yeah.
Able to see the patient better?
Yes.
Is that yes? Okay. And now, you're doing your job, Rick Burnham's doing his job, Michaela's doing her job, Chris Castle's doing their job, and there's a lot of people end up walking through the room, isn't that correct?
Yes.
Okay. And Kevin's there. Are you completely aware of what everybody's doing every moment while you're in there, besides yourself?
No.
That's all I have. Thank you.
Further redirect?
No, Your Honor, I would ask that this witness be excused.
Any objection?
No objection.
All right, you can be excused. Don't discuss your testimony with any other potential witness.
That's right.
All right, we're going to take our lunch recess. Close your notepads.